breathe and go. So it was supposed to be an entire session. I can't probably take you through the entire topics in this. So we are just going to tackle PCR and different ways of managing the PCR at different stages during the surgery. Now here I have already made all the pieces and suddenly I find a rent there. So that's where you take a pause, take a deep breath, and now you decide what is to be done. But one thing you will never let go is your foot switch. Form the chamber with a dispersive viscoelastic, and then get all the pieces into the area in which the break is not there. So you're going to just bunch it up over that area, and either that or take it into the anterior chamber. And you can continue with slow-mo phaco and complete the case. So with a formed vitreous, what you have to understand is the vitreous acts as a scaffold and in fact doesn't allow your pieces to go down. The only thing when it takes it down is when you increase the turbulence in the chamber. So here I have decreased my aspiration to 20 instead of 26, and you just continue with the phaco and the pieces go on coming to you and the vitreous strands do not come into the phaco tip. After that you can stain it with triamcinolone and do a vitrectomy. Now this patient was posted for a toric IOL. So we were assessing how much of support do we have in the bag, because it's a hydrophobic toric IOL. Anyways, I wouldn't want to put any IOL in the sulcus, which is a single piece. So here I'm using the vitrectomy cutter in the IA cut mode, which is really helpful. So you can aspirate and eat the cortex at the same time. Now you can see half of the PC is gone. So now this is not an ideal scenario wherein I can put in the toric IOL. So definitely I'm going to put in a 3-piece IOL out here in the sulcus and then do a optic capture posteriorly through the capsule. Now case number 2 is a tear which happens during the eye, and there you have it. Again the same principles. You're not going to let the chamber shallow down. You can see the flap is moving, so you can actually use a double-handed technique in which you lift up the flap with a Sinskey hook and use a microrhexis forceps from the side port to do a CCC and put in a toric IOL in the bag, and it works very well and you don't have a vitreous loss because you picked up the rent at the right time. This is case number 3 wherein it just gave way, the PC, and I have a huge triangular flap out there now. I try to do a PCCC out here, but it's gone too much to the periphery, so there's no point in trying to do a PCCC. But this patient is for a toric IOL. So here I see which axis it is in, and I have plenty of support in that axis. So what I do is I gently nudge the haptics into the bag where the capsule is intact, and then rotate it reverse because the other side haptic is not in. It's easy to for you to rotate back into position the other way around. That's anti-clockwise. And then slowly nudge the other haptic also inside the bag, and then do a anterior optic capture for this patient. So here the main thing is your exercise should be somewhere around 5 millimeters when you're operating. So if you're aiming at 5 millimeter always, you can always salvage these kind of cases. Now this is a patient in whom I had already done a toric IOL in one eye, and I thought I would get away because even in the previous eye I had not used a pupil expander. So I had just finished off all the chops and the pieces, and I was looking at the last piece out here, and suddenly I see that the things are not too well. But I am not able to assess the posterior capsule because the glow is bad, because the pupil is small, but there are nuclear fragments in the bag. So as in the first case, I get the pieces out into the chamber, go to a slow-mo, I'm at aspiration of 20, IOP of 26, and then finish off the aspiration of all the pieces. But at this stage, I feel that I'm not having good visibility. So this is the time I use a Malugan out here to expand the pupil and assess my damage. So Malugan can be used at, or any, for that matter, any pupil expander can be used at any stage, and you should be open to it and just use it so that it makes the life easy. And again, I'm using the vitrectomy cutter out here to do the vitrectomy as well as the eye cut mode for the cortical aspiration. But as you see, the rexus is the PC tear is quite a bit. It's more than half the PC torn. So again, in this case, I choose to put a 3-piece IOL instead of the toric IOL and put it in the sulcus, and then do a posterior optic capture for the optic. Thank you.
Yeah, very well demonstration of all the cases. Just one question for you.
Yep.
You had two cases where it was you had planned toric IL. So how did you manage the astigmatism later on?
So fortunately, both the patients were T3 model, so it was a
It was not
0.75
significant.
to 1 diopter.
Suppose
So
it was a T8 or
a
T9.
T8 or a thing, we could have later on tackled it with a LASIK or any other treatment.
Sulcoflex, overlays.
Sulcoflex, if I've already a IOL in the sulcus, over that would not be such a great idea.
Thank you.